Well, hello and welcome. Hello and welcome. Yes. I was like, they often call me the resident cheerleader because I've got a lot of energy. So I need for you guys to bring the same kind of energy that I'm bringing. So we had a wonderful morning session, and I'm excited about this afternoon session. I'm extremely excited about this afternoon session because we're going to talk a lot about health solutions. So I think we're going to start off with this wonderful keynote by one of my dear colleagues, Joe Richardson, and then we're going to have the panelists we're going to have the moderator and the keynote have a little discussion, and then the panelists are going to give small remarks, and then we're going to open it up for questions. If you look on your chairs, you will see note cards. If you have a question or a burning something you want to talk about, please write it down, give it to one of us, and we'll make sure that your question gets answered at the end of the panelists giving their words. So welcome again. I think you're in for a super duper treat, and I'm going to turn it over to the moderator for this session, which is none other than Stephen Thomas.
Good afternoon. Oh my goodness, come back up here, Chris. They didn't lost everything. They didn't lost all the. Good afternoon. All right. You know how awesome this conference is? Be mindful we're being also broadcast across the internet, where thousands of people are watching what's happening here at the University of Maryland. I think this is a very transformative meeting. My name is Dr. Stephen Thomas. I'm a professor in the Department of Health Services Administration in the School of Public Health and director of the Maryland Center for Health Equity. I have the honor and privilege of introducing our keynote speaker. Dr. Joe Richardson is the director of Violence Intervention Research Project at Prince George's Hospital Trauma Center. It is one of the busiest level 2 trauma centers in the United States. He is the principal investigator on 2 longitudinal studies looking at use of qualitative research methods in exploring this area of violence. The first study examines the risk factors for repeat violent injury, linkages and barriers to care in HIV, and related behaviors among Black men treated at Prince George's Hospital for violent injury, gunshot wounds, and stabbings and assaults. The second study, funded by the Robert Wood Johnson Foundation, examines the role and function of the Affordable Care Act in the navigation function, navigating people to insurance, specifically the experience of enrolling victims of violence and injury into health insurance coverage. His research has appeared in the American Journal of Public Health, the Journal of Urban Health Ethnography, the Journal of Family Issues, Spectrum and New Directions, and Child and Adolescent Development. I know Dr. Richardson from the work that we've done in a program here called Advancing Faculty Diversity. It's a year-long program designed to increase the likelihood that underrepresented minority faculty are successful in the promotion and tenure process. I'm happy to say that Dr. Richardson has indeed been promoted to associate professor with tenure. Put your hands together, will you? There you go. Let's bring him up to the microphone. Come on, Dr. Richardson.
Now we'll pass around the collection plate. All right. So, good afternoon. So, I am here to discuss solutions, but I first want to say that, and I see Reese. How you doing, Reese? So last night I had the fortunate opportunity to attend a private screening for The Birth of a Nation. And I can't say enough about when the movie actually comes out that everyone should see it. But one of the things that I left with from that movie is I'm going to talk today about invisible wounds and post-traumatic stress disorder among many of the young Black men that I work with that have come into the trauma unit that I've followed for the past 2 years of their lives and how they deal with many of the mental health issues around their injury. But what I wanted to take away, what I took away from that movie is, in the film, is that our wounds have been enduring for centuries. And the invisible wounds that I'm going to talk about today in no way can compare to the structural and physical violence that has been experienced by Black Americans for centuries. And I think that this talk kind of contextualizes that trauma, but in the sense of direct trauma that's interpersonal between young Black men, but also as violence of the state. So I just want to provide that as a context for this discussion. So in addition to my many hats as an ethnographer and a director of the Violence Intervention Research Project at Prince George's Hospital Trauma Center, I also co-direct what is called the Capital Region Violence Intervention Program. We are one of 36 hospital violence intervention programs in the country, and we provide psychosocial services to victims of violent injury, and I'd rather say survivors of violent injury, with the intent that we prevent trauma recidivism. And that is when we have patients who are involved in the cycle of violence and continue to come back to the hospital for similar injuries. And so nationally, anywhere between 30 and 60% of the young men that have been violently injured in the nation will come back to the hospital within the next 5 years for a similar penetrative injury, and 20% of that population will die. And so my job and the job of our staff is to make sure that we provide the social services as well as psychological support to prevent those young men from returning to our hospital again. And so this is a quote that I think kind of summarizes the work that I do. And the Violence Intervention Research Project has been used as a component of our violence intervention program to inform the development of it. And so this is a quote from one of the trauma nurses that on my floor regarding invisible wounds. And so it says, "We do a great job patching people up. That's nothing. We are good at that. Addressing their physical trauma is nothing. But what we cannot do is patch up their mind. We just send them back out there with psychological wounds. The body does a great job of healing itself, but the mind is totally different. So we have to deal with their invisible wounds, the wounds in their minds, because it is hard to fix what's up here." And so much of my discussion today will focus on the psychological wounds of dealing with a violent injury. So you see these two handsome guys? The guy up front, he's really nice looking, right? So the young man behind me is my mentee. His name is Che Bullock. He's also a survivor advocate for our violence intervention program. And I met him through the trauma unit when he was medevaced to my hospital because he was stabbed 9 times, multiple times in the chest. He almost died. And I met him at bedside in our hospital. And from that point on, we developed a relationship. And often in ethnography, when you develop really close relationships with people, they often extend beyond just the study. And so Che has been a valuable person in my life and as well as in the lives of others in trying to prevent violent injury from occurring. And my discussion today will focus a great deal on many of the discussions that I've had with him and some of the quotes that I've taken from my interviews with him. So this is just a brief clip.
Okay, so this is our first tape, and I want you to begin by just telling us your name, your age, a little bit about yourself, where you're from, all that.
Well, my name is Che Bullock. I'm 26 years old. I'm from Washington, D.C., Alabama Avenue, Southeast. I have 2 sons. I have 2 boys, Keon and Peyton. One is 4, the other one is 1. And I live my life for them.
Okay. So what was it like for you growing up in D.C.? What was life like?
life in DC was just, it was good times and bad. It rained and I guess the sunshine, it shined. It was a lot of poverty. It's a lot of poverty in DC. I went through a lot of things as far as poverty. So,
And when you were growing up, did you see any violence in your neighborhood?
I seen violence 24/7. Violence is every day. Every day. Wasn't a day went by that I didn't see some type of violence.
Can you remember any times, any incidents you've seen?
Yeah, I remember one time I was in middle school and a young guy got killed. I want to say he's about 17 to 18 years old. I was around 13. It was around 2 o'clock in the afternoon when school let out. My mother was coming down the stairs and they had a yellow tape around, I guess, some poles. And my mother seen the guy's legs. So when she seen his legs, she told me that she looked at his feet and she was trying to recognize if the shoes that he had on were any type of shoes that I've had. So for a second, she thought that was me on the ground.
So when I met Che, he was, as I mentioned, he was medevaced to my hospital. And this is a quote from one of the interviews that I had with him, and we often ask many of our participants to write some of their own personal notes. And so this is what he had written about his experience being transported to the hospital. They put me on a helicopter and medevaced me to PG Hospital. By the time the helicopter landed at the hospital, I was feeling very weak. They pulled me off the helicopter, and I remember looking up and seeing a long hallway with white lights. At that point, my hurt turned to anger. I remember thinking to myself, I'm going to kill his whole family if I make it out of this. This is where we enter as advocates in the process of reducing violent injury, but also reducing retaliation. And so many of the young men that we encounter in the trauma unit, although they've been victimized, they've also offended. And so one of the ways that we try to interrupt the cycle of violence is by interrupting at the time when we know that we have an opportunity and a captive audience in order to convince and persuade many young men to join our program. So this is a snapshot of Prince George's Hospital. This is our helipad where Che and other young men are medevaced in. This is a picture not in our hospital, but of a young man on a trauma table. And this is Dr. Cooper, who is the chief medical officer on the right. And this is part of our trauma team. And Dr. Cooper's on the left. And also, he's also one of my mentors. And this is part of our trauma team. I also see Dr. Green from Prince George's. How you doing? So, as I said, up to 45% of people who had a penetrating injury, a gunshot or stab wound, will have a similar injury within 5 years. And within 5 years of their initial injury, 20% of these individuals will die. And so, in the spring of 2013, in order to inform this study, I recruited at Bedside, along with my colleague, my postdoc, Dr. Christopher St. Ville. We recruited 25 young black men between the ages of 18 and 34 that were the victim of either a gunshot wound, a stabbing, or assault. And Prince George's Hospital is the busiest level 2 trauma center in the United States. We treat over 700 victims of violent injury per year, and 1 out of every 5 patients that comes in for a traumatic injury, whether that's a car crash or fall, is for violent injury, 20%. And so this is just some of our data for 5 years, and you can see at the total, at the end of 5 years, between 2009 and 2014, we treated over 4,000 people for violent injury. And this is the catchment area that we serve. So since we are the closest hospitals to Ward 7 and 8, which are in Washington, D.C., and we also are situated within the Beltway, we respond both to young men who have been injured in D.C., as well as young people who have been injured within the Capitol Beltway. And so in trauma informed care in hospital violence intervention programs, we have what are known as the golden hours. And so the first golden hour is responding to patients medically within an hour to save their lives. There's an article called Murder in Medicine, which has been written, which discusses how victims of violent injury can be saved if they get to the hospital within a brief period of time. And I'm not sure if many of you know that there have been massive protests in Chicago regarding the lack of a trauma unit on the south side of Chicago. And recently, there was money used to fund a trauma unit, which I think will be in operation within the next year. But we have a responsibility to treat patients within the first hour to try to save their lives. The second golden hour is when people are more likely to be open to changing the factors in their lifestyles that made them susceptible to injury. And so we can reach them within the first 3 days or at least within the first 24 hours of their injury. We have a greater likelihood of persuading them or trying to persuade them to change their lifestyles from the risk factors that led to their injury. And so recruiting them at bedside and approaching them at bedside when they're cognizant enough to be receptive to joining our program is when we try to meet with them. And then the third golden hour, I think, is the most important golden hour, and it's the phase which we call treat and street. And so in many situations when a young person has been violently injured, they're often treated, patched up, and sent back to the same neighborhood where they've been injured. And so many of the young men that we work with suffer from psychological wounds similar to what you would see a soldier in Iraq or Afghanistan suffer from. But what we do is we patch them up really well, we send them back out to their communities, and then we hope that they don't come back. And so going back to the block is the third golden hour and the most important golden hour. And this is when we have to deal with issues around reputation, retaliation, and redemption. And so when I met Che, while he was in the hospital, his friend was murdered. And so you can think about, during that period of time, what we had to do as researchers, and we're not therapists, but what we had to do as researchers to try to prevent him from giving the green light to young men that were part of his crew to go back and kill the person that stabbed him and also the people that killed his friend. And so we have to try to conquer the addiction. And many people think about the addiction in terms of substance use, but we can also think about addiction in terms of violence, hustling and selling drugs, and also getting young men who are selling drugs to transition from getting fast money to slow money. And when Che was discharged from the hospital, within the first 3 months that he was on the street, he was shot at twice. And in one situation where he was shot, his car was shot multiple times, and he managed to survive. And so clearly, being exposed to chronic violence causes a number of symptoms that are characteristic of PTSD. And so what many young men experience are flashbacks of re-experiencing, thinking about the situation over and over, avoidance, avoiding their friends and sometimes their families in the place where they were injured, emotional numbing, being very desensitized and almost fatalistic, and then hyperarousal, being very vigilant about their surroundings and never being able to move out of a sense of fight or flight. And so during this period of time when Che was discharged, he wore a bulletproof vest all of his waking hours. And in fact, I clearly remember the day when he decided to take his bulletproof vest off in front of us, in front of myself and my postdoc. And he always carried a gun. And so the other thing is the issue of self-medicating. And so what we find is that young men who have been treated for their psychological distress often rely on drugs to self-medicate their trauma. And then adverse childhood experiences where we have trauma recidivists and young men who have been injured multiple times, but their injuries started much earlier in their lives. And we have young men who have been abused as early as 3 or 4 years old. And so this is a quote which captures kind of the emotional numbing that Che experienced. I don't really care about people or who's in pain. My trust of the public is gone. I always carry my pistol with me. I really don't care too much about life. And then we have to address issues of identity, which may lead to retaliation. And so here Che is discussing how his identity was lost when he was stabbed. I lost my identity. I felt like I was less than a man because I felt like that situation violated me. After that, my gun got bigger. I went from a 38 to a 45. I felt violated, so I was trying to get my validation back. And a bigger gun made me feel like I had more power. I wanted the world to know I had more power. And so we also have to think about when we're dealing with a person who has been violently victimized is the trauma that their family members also experience. And so this is Che discussing how his sister felt victimized by the situation. And so it's not just about the person who was victimized. The invisible wounds happen now with people around me. Now my sister wants to kill everybody around me. She might have more trauma than I have, and I was the one who went through the situation. And then finally, again, although we are not therapists, our presence managed to deter Che from engaging in future violence. And this is mentioning our effect and impact on that trajectory. And so me not killing him or anybody in his family was because of you, me, and my co-investigator, Chris. To be honest, Doc, that's the only reason this family got a pass is because you reached out to me. So you saved my life and his family's life. You guys interrupted my mental process with that because as soon as I had the power to get away with it, killing him and his family, I would have done it. You stopped my criminal mindset and developed my human mindset. You guys turned that killer mindset off. But I had to wean myself off that killer mindset because I was addicted to it. You really have to break yourself down. You damn near go insane trying to rebuild yourself. And so this is why we need a violence intervention program. And I've heard on many occasions that we have the interrupters and ceasefire, but we really try to bring a public health solution to many of these problems. And by capturing someone at bedside, I think that we can do a really effective job at interrupting the cycle of violence. So the Capital Region Violence Intervention Program, which the acronym is CAPVIP, we have a social worker, or we're hiring a licensed social worker. We now have hired Che as a survivor advocate and a patient navigator, and I thought that it was really important to have someone who has been violently injured serve as a survivor advocate, because we need someone who is able to identify with the young men and young women that we serve. And then finally, we also have the Affordable Care Act navigator. And it's very important that we have a navigator because the majority of young men that come into the trauma unit are uninsured. And so one of the things that I realized when I was conducting my research is that 92% of the young men that were in my small sample, 23 out of the 25, did not have insurance. And so what ends up happening is that either the hospital will eat the cost or that cost is then deferred to the patient. And so there are hospital funds that cover the cost. But I've seen hospital costs for young men go anywhere from $20,000 up to $200,000. And so what we need to do is begin to connect young men to the health care coverage system, as well as connecting them to primary care physicians, because many have never seen a doctor or a dentist, and it's almost non-existent that they've actually been treated by a mental health therapist. So it's very important that we also make sure that our young men, before they're discharged from the hospital, that they are enrolled in healthcare insurance. And then finally, we do community outreach. So we have a violence prevention program, and what we do is we go into many of the high schools, the junior high schools, as well as recreation centers and public housing projects in the National Capital Region, which is Prince George's County and DC, and we give talks to young people about violence and it's trying to prevent them from engaging in violence. And so we use what is called a trauma-informed care approach. where we adhere to 6 principles. One is safety, the other is trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and giving our patients a voice and choice, and then their cultural and historic gender issues. And what we're using now is called the MTREM. It's the Men's Trauma Recovery Empowerment Model. It's an evidence-based model used by SAMHSA. It's 24 weeks, but we've trimmed it down to 12 weeks, where there will be 2 sessions twice a week, and those sessions will cover substance use, anger management, and familial issues. And so again, I mentioned that we have a violence prevention program. Right now I have my class, which is almost serving as our pilot project, where I have my class for my qualitative methods course. We're working with Suitland High School Hillside program. And then our violence prevention program, we also do something that's called the 3 C's, and we try to emphasize the importance of social capital and human capital, which will ultimately lead to financial capital. And we need to shift the paradigm of young people thinking that financial capital should come first, and that they should begin to develop their networks as well as their educational skills and credentialing, which will ultimately lead to financial capital. So we heavily emphasize delayed gratification. And so these are some of our partners. Again, we're part of the National Network of Hospital Violence Intervention Programs, which are 36 programs situated in Level 1 and Level 2 trauma units. We recently had the DC Executive Office of the Mayor reach out to us because they found out about our program through Cure Violence, and they've committed to providing us with support to provide psychosocial services to young men who have been injured, that have been victims of violence, that live in the District of Columbia. And so in addition to that, we shot a documentary. It's called Bullets Without Names. You can pull it up on Vimeo. It's a 10-minute documentary. It was nominated for awards. We didn't win any, but I think it's a powerful documentary nevertheless. I won't show you that. This is one of our young men, E, who he's holding his graduation certificate from DC Department of Employment, and he's now working at DC Kitchen. And then this is Che. So the transformation happened with Che over a course of 2 years. This is Che actually guest lecturing my class. And so from what you saw from the very beginning, and I've tried to take you through that narrative, he's now guest lecturing my class. This is him at Suitland High giving a talk, and now he's in high demand. He gets paid a lot of money as a motivational speaker. I don't get a cut. He spends a lot of time as a motivational speaker. Actually, last week he was invited to the University of Delaware and gave a talk for 1,600 people. And so this is like one of our success stories, along with E and many of the other young men that we work with. And so the other thing that I want to emphasize is that I also had written an article for the Journal of Urban Health, and Dr. Ray and Dr. Gilbert were also published in that special issue on police brutality. And my article focused on how hospital emergency departments could do a much better job at collecting data on police shootings. And so I'd written an article, it's called Who Shot You? And it really emanated from my studies in the hospital, where I would get a trauma log every day, and the trauma log would have the person's injury, their name, their birth date, and then their room. But at times I would get to the room and I could not access the room because they were guarded by the police. And so in the midst of the national dialogue and discourse on police shootings, what I realized and what we know now is that we have absolutely no data on how many people are shot by the police every year, fatally and particularly non-fatally. So we have 2 independent news sources, the Washington Post and the Guardian, which have documented in 2015 how many people were actually shot by the police. Well, the FBI over the past 10 years has recorded 400 fatalities by the police every year, while the Washington Post and the Guardian is upward of 1,000. And we know that far more people are non-fatally injured than fatally. And so we have no idea how many people are shot by the police. And so what I proposed is that hospital violence intervention programs like the one I direct should be engaged in asking patients that question. Since we ask questions about the context of injury and the perpetrator, but what we have done a really poor job of asking is whether a person was injured by law enforcement. And there is an ICD-10, which is a code that hospitals use, which can capture law enforcement. So it's not a question that cannot be questioned or asked. It's a matter of whether we standardize that in hospitals across the country. And so my primary goal is to make sure that we pilot that in our hospital, and that out of the other 36 or 35 hospital violence intervention programs, that they begin to engage in that work so we have an accurate account of how many people are shot by the police every year. And as I make the argument, it's not about whether it's the innocence or guilt of the police, but collecting the data because we have none. And that's primarily because the FBI does not require law enforcement agencies to submit police shooting data. And only 3% of the 17,000 law enforcement agencies in the country have supported data denoting how many people they've shot. And so it's imperative that we find alternative ways to document that. And so this was an article that was published in the Journal of Urban Health, and then it was picked up by NPR, and it was run nationally, and it caught a lot of press coverage. And I'm very happy about that, not just because I had written the article, but I think it's an important article, and I think it's an important approach for hospitals to begin to document what are systemic problems with police brutality in this country. And so I won't hold you any longer. I hope I've covered just about everything that is trauma-related, and hopefully you will get more information out of my Q&A with Dr. Thomas. Thank you.
What a presentation. Stay up here to the mic, my brother.
All right.
Give his brother a hand, will you? You know, being promoted and tenured is never easy, but there are easier ways. He took the hard way. Qualitative. A lot of people do the work just behind the computer, never leave their office. Qualitative. And my question to you is just the way you talked about Che, your mentee. Mm-hmm. You know, that sense of the relationship you built with him. And I want you to say to this audience, to what extent do you think that you were able to build that kind of relationship? Because when you looked at him, you could also look back at yourself.
It's a very interesting question. So the first thing that had really drawn me to him was his name. And I mean, how many people do you encounter named Che? So that's beside the point. But I work as, particularly as Black scholars and interacting with other Black men, we rarely think about how our past experiences have framed our research. But for me, it's very personal. My grandmother was murdered, my uncle was murdered, and I've had friends that live in my neighborhood murdered that I know. And so when it affects you both personally and professionally, it has framed everything that I do. So I kind of live and breathe it. At times it's very stressful, but at the same time I owe it because I'm just a vessel. And you know, I don't write these words. I don't write the words that I say in a presentation. I'm just a vessel for the higher God above that uses me to do the work. So for me, it's a labor of love. I would never quit it. I was dedicated to having a hospital violence intervention program since the very first day. I saw Dr. Cooper on CNN and Black in America, which was roughly 2009. I saw his program on a segment of CNN with Soledad O'Brien, and I knew that it was the work that I really wanted to do. And so I reached out to him, and since then, he's given me open entree to use the hospital as a lab to do this kind of work.
You know, every time we talk, I learn something new, and maybe people in this audience learn something new about you, that violence had touched your life. Mm-hmm. And we talk to our graduate students, our young faculty, when you do your research, you need to pick something you're passionate about And now I understand why this is so meaningful to you. But when every single day you're working with young men who have been traumatized by violence, to what extent does it ripple to you? And how do you deal with the trauma of working in the area of trauma?
It's about self-care. You know what I really found to be interesting when I first started is when I would hear the conversations between Dr. Cooper, who's a trauma surgeon, and Dr. Benoit, and they would discuss young men who had expired, and that's a pretty interesting word in itself, but it was always really kind of sterile. And initially I just felt, how could they talk about lives in that way? But after doing the work, I think that you have to develop that kind of, I think you have to, but also I think over time you develop that kind of demeanor and approach to it. But that doesn't mean that my sense of humanity, I've thrown that away because I would just continue doing the work. But I can clearly understand how you have to kind of emotionally detach yourself in certain ways from doing the work, which is why I live really way out in a very rural place, so I can decompress. But it's about self-care, but it's also knowing that it's also rewarding, and knowing that you've changed someone's life, even through your own scholarship. And so you look at the work of Du Bois and the work that he used to inform interventions, and I think as scholars, and particularly as scholars of color, we owe it to ourselves and our scholarships to not just sit in an ivory tower and do publications and peer-reviewed publications and conferences, but we also owe it to make our work translate into interventions and to apply it. And if you can't do it yourself, you need to find other people that you can connect with that can make those connections to develop those interventions and to push those policy forward. And everyone doesn't have to be an activist in the way that we know activists. We don't all have to be on the front line. We don't all have to wave, the banner of Black Lives Matter, but we all need to be our own Nat Turners. We all need to be our own revolutionaries in whatever way, shape, or form we see that. And we owe it to ourselves, and we owe it to our communities.
Well, what I'm so impressed with, and I hope that you and the audience are as well, that going through a process like in this academy, a predominantly white institution, pursuing a theme that is personal to you, that you can do that, you can succeed, and you can still have your own self. You're still your own self. You have not denied who you were
Very
in
much
order
so.
to be successful.
No.
So when you think about those young men that you've worked with, and you're the professor, at what point were you the student to them? And what can you summarize as the lessons they taught you?
I'm always a student. I don't think you do this work without coming in with that mindset. I'm always a student first. There's so many things that I've learned about humanity, humility, that for the luck of the draw, I could be this person lying in that hospital bed, about structural violence, issues around police brutality. There's so many issues that I've learned from them, and that I think that they're really resilient, and we don't give them enough credit. And there have been several studies that have, not studies, but there have been papers written about how young Black men are often perceived in the trauma unit, and it's perceived by some surgeons or trauma staff that they were guilty and they're the ones that did it. But I totally don't buy into a lot of that nonsense. And I do agree that one point that we have to make, because that's the narrative, I heard one of the other panelists say that we have to put a price tag on it. And so what I really try to do is put a price tag on how many lives we're saving and how that can reduce costs. And it's unfortunate that I have to do that, but that's the only way that people will buy into it. And so it's important for me also to tie in the economics of it, because we spend over $400 billion a year on violent injury, but these programs are really effective and work. And if they can reduce the number of people that are coming in and they can save costs, then I think it's the best interest of the hospitals to invest in them.
Now, you know that before you became the tenured associate professor that you are up here right now, there may have been people along the way that said, hey, if you continue to do that work out in the community, you won't be successful. What kind of pushback did you get from those who were above you, who had authority over you, who had a sense of the control and a sense of your future in an environment like this? What kind of pushback did you get, and how did you overcome it?
I think for me, initially as a doctoral student and at Rutgers School of Criminal Justice, and many criminology programs are really highly quantitative, and I knew that I didn't want to be a quantitative researcher, although I'm moving slowly, unfortunately, to the dark side of mixed methods. But I knew that I wanted to be a qualitative researcher, I just didn't know how. And I was fortunate that a mentor came along in my department and offered me the opportunity to do ethnography. I had no idea what ethnography was at the time. And I ended up conducting a longitudinal study in Harlem with adolescent boys and girls over a 4-year period. And from that point in time, I was pretty much married to it. But you had to get over kind of the hurdles in the field that it's really not an acceptable method. And unfortunately, right now, it's becoming much more mainstream and acceptable. I think the next step is visual ethnography, and hopefully I will continue to engage in that. But also, many researchers for gun violence were told not to engage in it because the CDC is not funding it. And so we have a 20-year unfunded mandate since 1996 that the CDC has not funded gun violence research. And that's primarily because the CDC has advocated gun violence as a public health issue, which then the NRA turned into an issue of gun control. And so they've tied their politics into the NRA, which has ultimately led to gun violence research not being funded. And so many gun violence researchers were persuaded by their mentors not to go into this kind of work because it's really not any money in it. And it's very hard to sustain a violence intervention program too. And so that's the other difficulty is how do you sustain these programs? It's kind of easy to get it off the ground, and we've been working on a shoestring budget. I've basically worked for nothing, but we need to, and then we're finally getting physicians that are going on to the congressional floor at hearings and advocating for Congress to put money up for gun violence research. And Obama has legislated $10 million, but still the Congress won't let that funding go. So that's the other thing. There's structural issues that are involved in it too. So you have the cultural issues in academia regarding qualitative research and criminology and violence and crime, and then you also have the structural issues of the research climate.
Now we're going to open this up and have our panelists come. So my last question, and then we're going to continue this conversation and bring the rest of you into it. I was actually very impressed reading the narratives. In qualitative research, those quotes came right from Che.
Right.
I pronounce his name right?
Yeah.
Che.
Yeah.
And there was a certain poetry to just what he said to you. And as you look back over those narratives, not only of Che, but the other men who sometimes simply get marginalized because of where they lived and where they came from and why they were in the hospital, there was a certain poetry, a certain wisdom, a certain deep thinking in his narrative. And I want you to talk a little bit about what that told you about their intelligence, their contribution to society as a result of doing this work.
I mean, they are poets, and when you're documenting it, what they're saying, and you allow them to read it, and I remember Che reading it, and he just kept going over and over. Let me read it again, Doc. Let me read it again.
He's reading his own words.
Yeah, he can't imagine like this is what I said, but they're all gems and diamonds in the rough, and just for structural reasons, didn't have the same opportunities. And so our program is, the intent is to provide those opportunities in one way or the other. But they're very reflective when given the opportunities and the resources to be successful. The vast majority have, and again, it's a matter of the funding and how much we can fund and the people who are really committed. And that's the other thing, is that I just entered it not just being a researcher, but you find yourself as an ethnographer really drawn to the humanity of people, and that's hard to divorce yourself from, even when the study's over.
Well, I enjoyed the photograph of the young man holding her certificate because I saw in his face
He was happy.
not only the pride that he had and the happiness he had, but every year I see that when our students walk across the stage to get their degrees, it was no less happy than our students have when they walk across that stage. Thank you for being the scholar that you are and opening up a way for doing work that can make a difference. Let's give Dr. Richardson a hand, will you?
Thank you.
I'll ask you to stay up here on the stage. Our panelists are going to come up and give just a brief snippet as they reflect on the presentation and contribute to the broader discussion that we're going to have. And then we're going to open this up. This is no time to be shy, audience, when we open it up. This is a time to be bold. The first person I'm going to call to the stage is Dr. Janice Johnson Diaz. She has dedicated her life to examining and ameliorating the economic, political, and social factors that influence health behaviors, outcomes, and opportunities of impoverished mothers. Just come right on up, Dr. Diaz. I'll be the timekeeper. And do you have to set anything up on this machine here? It's already on there? Okay, get it where you need it to be. And I'm going to turn the mic over to you. While you're doing that, I'm going to say a little bit more about what you do.
Okay.
One of her initiatives, her most recent work in Long Island with Stony Brook University and community stakeholders on issues of black girls' mental, sexual, and physical health, earned the collaborative and special congressional honor. Let's give her another hand, will you?
Okay. All right. Hello, good people. I know that it is late. It's 2:53. I've already had several cups of coffee, so I'm good. So a part of my charge today is to talk about strategies, health strategies, especially as we think about racism in sickness and in health. So I spent a lot of time thinking about it because of the good academics in the room, and I play one as an associate faculty at John Jay College, and I really live one as the president of the Grassroots Community Foundation. And so the work that we do is the work of addressing health inequality and promoting wellness. So we don't spend a lot of time actually regurgitating or rearticulating the challenges around racism, but we begin and we do our work around trying to find strategies that are going to undo racism, and specifically undo the impact of racism on people who live in bodies that are designated and considered black and brown. So at Grassroots, we are a public health social action organization. We were formed in 2010 after this congressional award, in largely response that people felt like I ran out of time. I had no place else to go. And my partner, as many of you might know, if you watch The Late Night with Jimmy Fallon, is Black Thought of the Roots. So we have combined social science with hip hop in order to make the changes. Today I heard one of the panelists talked about the First Lady's Let's Move initiative, and it was really in direct response to what I felt were, while a good idea, one of the worst ideas because it was so rooted in individual action. So our work really begins at the individual level and extend to both the institutional and macro levels. We run a camp specifically designed for girls of African descent, where we teach them African and African American history, and we also teach them to do something which I'm going to show you a short little video on. We teach them to engage in social action. And so we start with girls as early as 10 years old and teaching them how to address social and economic inequalities. And one such girl is her story will be highlighted here.
Wisconsin found that of the 3,500 children's books it received last year, only 261 were about black people, and just 100 came from black authors. One New Jersey sixth grader isn't satisfied with numbers like that, so she showed Vanita Nair how she created a new chapter.
I am born on a Tuesday at University Hospital, Columbus, Ohio, USA.
For 11-year-old Marley Diaz, a good book opens the world.
You always have words. You're able to express your emotions when you read The People Who Look Like Me. Keep fighting.
But there are some books she's assigned in school she's grown tired of.
The books were just mainly about white boys and dogs. I read Shiloh, Shiloh 1, Shiloh 2, Shiloh 3, Where the Red Fern Grows, and a bunch of other ones. I'm sick of it.
Marley wanted books she could relate to, with characters like her.
So I just went to my mom, and then she told me, well, what are you going to do about it? And that's kind of how the book drive started.
The idea was simple but ambitious, to collect 1,000 books about black girls.
And we started posting pictures on Instagram of me holding black girl books and pretending to read them. And then we added the hashtag, and now it's become a full-on book drive.
How did you come up with the hashtag?
Well, we know that social media is like the main outlet for us to get anything that we want now, so we need to be fun, catchy, and just something easy to remember. So we wanted 1,000 books, and we wanted them to be black girls, so you just kind of smack them together, and you've got a hashtag.
Were you ever nervous that you wouldn't be able to find 1,000 books about?
100%.
But that nervousness has been replaced with excitement. First, local media got wind of her drive.
So please welcome Marley Diaz, everybody.
That led to appearances with Larry Wilmore on The Nightly Show.
And your name is Marley. That's such a good
Yes.
name. Were you named after Bob Marley?
Yes, my mother is Jamaican,
Really?
so she named me after Bob Marley. I have to do my homework, so during your show time, but I'll always be on YouTube watching your videos.
And with Ellen DeGeneres.
You need to figure out your priorities because it should be my show, then homework, but that's all right.
So did you guys just decided to start putting them on the floor?
Yeah, it's kind of easier to organize them.
The books began arriving and stacking up. When we visited, Marley had collected close to 1,300 of them.
Do you have a favorite book that's come in?
Yes, to the giant stack right there, Brown Girl Dreaming by Jacqueline Woodson.
Woodson, who won both the prestigious Newbery Award and a National Book Award for Brown Girls Dreaming, knows the importance of identifying with characters in a book.
Seeing a story on the page about a black child written by a black author not only legitimizes your own existence in the world because you're a part of something else. Look, I'm here in this book.
I'll get the scissors from the cabinet. A picture poetry book. Okay, this looks cool.
So what are you guys gonna do with all the books?
So 1,000 of the books are going to go to St. Mary Jamaica Primary School, where my mother is from. And it's gonna be my first time going to like rural Jamaica where she's from. This campaign started.
And last week, that's what they did. Marley and a team of volunteers gave away the books she collected to Jamaican children, many of whom had limited access to books.
Have you thought about what you want to do when you grow up?
Yes, I want to be a magazine editor for my own magazine because I love being the boss and I love reading and writing.
You know, I think you should consider writing your own book, though.
Yeah, I've heard a lot about that. I don't think I'm ready, but when I am ready, I will.
We're guessing that book will have a very impressive main character. For CBS This Morning, Vanita Nair, West Orange, New Jersey.
The point of this, and I will just take 30 more seconds, the point of this is that young people, if we think about their well-being, we want to be able to activate within them the sense that they can actually be self-efficacious and that they can actually penetrate some of these entrenched institutional systems that can go beyond their local neighborhood. But for us to be able to do that, it has to be a primary goal. We do have to begin with the end in mind of undoing racism in order for us to be able to cultivate strategies that will help.
Dr. Diaz, awesome. Yeah, come on, stay here. Very good. The next speaker I'm going to call up is Dr. Chelsea Cosby, medical doctor. Please head this way. Yes, all right, give her a hand. And I'm gonna brag on you while you have slides or anything like that? Yeah, I'll brag on you while you're doing that. Dr. Cosby is a family physician serving at the University of Maryland. serving the University of Maryland community at the University Health Center. During her medical training at the University of Maryland Family and Community Residency Program in Baltimore, she serves as chief resident and implemented a curriculum to formally integrate education on health equity. Give Dr. Cosby a hand, will you?
Hi, everyone. I'm Dr. Cosby, and I work over at Student Health, so hopefully I'll see some of you all over there. I'm one of the newer additions. But today I wanted to touch base on 3 themes that, from my perspective as a healthcare provider, are limiting our growth forward in caring for health disparities and addressing health inequities. First, minorities in research. Second, healthcare cost. And third, perpetuating racial bias in our medical training. So first, we know there's a long history of racial minorities being taken advantage of in research. So this is a touchy topic, but the issue is in medicine, whenever we have research studies, whoever they include, we're using those results to go forth and come up with solutions, to come up with best practices, to come up with guidelines. So if African Americans or Latino patients are not involved in those studies, they're not involved in the recommendations. So I do want to just use one example today, prostate cancer. The United States Preventative Task Force, it is a national government task force which provides information and guidelines for primary care physicians to diagnose and screen for lots of different medical problems. For example, diabetes, high blood pressure, strokes, breast cancer, and prostate cancer. Let's see. This is their recommendation on screening for prostate cancer. The prostate cancer screening test is called a PSA. It's a blood test. Very quick and simple. There's lots of implications whenever you do any kind of testing. I'm not saying it's all quick and simple, but this particular blood test is called the PSA, and the National United States Preventive Health Task Force says not to do it. Why is this important? Whenever they did these studies, most of the studies did not involve African American patients. The primary study they used included 4% of African American patients, yet all over the country, all primary care physicians are held to this gold standard. 1 out of 6 African American men develop prostate cancer, and Black men are twice as likely to die than white men of prostate cancer. So I feel like this is something that needs to be addressed, how we're using research in our guidelines. Next, the endless cost of healthcare. It's really exciting that now with Obamacare, we do have a lot more access to care for patients. But when patients come in and we finally get them in the door, like earlier we were talking about, a lot of these young men do not have healthcare. When they finally do come in and they receive healthcare, we give them a long list of medications they need to take, but no one can afford them. And we know that's a big topic of discussion, the price of prescription drugs, but it's very astronomically high, and I want to address that over here. This is a table from the Medication Expenditure Panel Survey, a national survey that collects information about how much medications cost on average. This is not out-of-pocket costs. These are costs whether or not the health insurance pays it or whether or not the patient pays it. It's just the cost of the actual prescription. So it's kind of small, but what it is saying of the 5 most popular medications or types of medications that are prescribed, these are the average cost per prescription. So I'm going to tell you what it says because it's kind of small. In the blue, this high column here, metabolic medications, which are diabetes medication, on average $100 per prescription. Over here, respiratory medications, $142 per prescription. That includes COPD medications and asthma medications. Diabetes, asthma, things that heavily hit minority communities and urban communities, things that are costing a very large amount. If you do have health insurance, that cost is offset. But the same medication expenditure panel survey does say on average, poor people or near poor people are spending $4,000 out of pocket on a year for their medical care. So even if you do have health care, you still have to have an extra $4,000 to get your medicines. And what they are seeing is that people who have chronic medical problems, most of the time you do have to have multiple medications in order to manage diabetes, in order to manage high blood pressure. And whenever you do have those medications, 1/3 of people with chronic illnesses are either food insecure, medication insecure, or both. And then finally, whenever we are talking about the racial bias in medicine, we're trying to improve how many people are of diverse backgrounds that we're bringing into medical schools. But even when we do bring in people that may be African American or Latino, are we really looking at how many people come from low-income backgrounds, how many people come from rural or urban backgrounds? There's a lot of examples about even when we bring people into the medical community, into medical schools, into residency training, are we still teaching them examples that can promote racial bias? There's a lot of discussion around some recent studies that came out it's repeating a lot of information from old studies, but it's still happening in 2016, evidently, that Black ER waiting times are longer than white ER waiting times, that Black bodies experience less pain than white bodies, and that we're undertreating Black patients for pain in comparison to their white counterparts. So clearly there needs to be a focused longitudinal effort to make sure everyone is trained on poverty, diversity, and health disparities. So just a few things I want to talk about, places to go forward with this, is formalize research on minorities, and how can we build the bridges to make minorities more comfortable in participating in these clinical trials, because it is impacting their health outcomes. And also affordable pharmaceuticals, that's a big discussion, but it is completely limiting people's health care. And then formalized education on poverty and diversity. Whenever we do bring people into the medical schools and into residency programs, are we honoring their traditions, or are we just trying to make them assimilate just because they look different, but treating them the same as everyone else? So hopefully we can talk about some of this more. Thanks.
Dr. Cosby. Let's give her a hand, will you? Right here, your own student health center, am I right? So you're right here. Very good. Our next speaker I'm going to call up is Dr. Ashley Hicks Rocha. And do you have slides? And while you're doing your slide setup, I'm going to brag on you a little bit. She is the co-founder of Black Girls Run, an effort to tackle the growing obesity epidemic in African American community and to provide encouragement and resources to both new and veteran runners. Give Dr. Hicks Rocha a hand, will you?
It's actually just Ashley Hicks Rocha. Thank you. I'm Ashley Hicks Rocha, the co-founder of Black Girls Run. My business partner Tony and I started Black Girls Run in 2009. And at the time, there were not very many African American women involved in your endurance sports. Do I have any runners in the room? Any walkers? Awesome, awesome. So when we got started, we didn't see people like us at races, out at running groups, just participating in this sport in general. So we started out as a blog, and we said, you know, is there a way for us to just give information to our friends, our family, some of our friends from college who are asking us questions about, why are you running? What does this whole running thing look like? So we started out and we blogged for 2 years, and we were able to create an amazing following, which was interesting because at the time this was before Facebook is what it is, before we had Facebook pages, before Twitter. We always tell people we were on Twitter before Oprah and everyone else when they were joining, and we were able to use these networks to really create a community of Black women who were currently runners. Then in 2011, we actually started our own running group. So we launched initially 30 groups across the US. It was pretty interesting. We just wrote on our blog, hey, if you're a runner and you're a Black woman and you want to have a running group in your hometown, email us. And as the emails were coming in, we're like, oh, wow, this is interesting. We had over 30 people respond wanting to start groups in their area. So we had those groups, and then we added 30 more, and now we have over 70 groups across the US. And one of the things that's been really impactful is that we have people who come out and they say to us, I never thought I would be a runner. This was something that was not on my radar. This is something that Black women just don't do. So for us, it's really been interesting to see that we've been able to create this change, that we've been able to change people's perceptions of what running is, what endurance sports are, and most importantly, we've been able to impact the way that people deal with mental health issues. So for us, Tony and I were not researchers. My background is television production. Tony's coming from a PR background. It was interesting to look up and see people were saying, hey, you know what, this is a new way for me to deal with stress. This is a new way for me to deal with the real issues that are going on in my life. So it was something very interesting that came out of this movement for us. And then lastly, what Black Girls Run really is able to contribute to our members is this online presence. So as I mentioned, when we started Black Girls Run, there were very few people on Twitter. Instagram wasn't even around. Facebook, like I said, didn't have pages. So we were able to slowly start to use these social media tools to create a following. And for us, it's people who may run in places where we don't have a group, so they're not in one of our 70 areas, and they're able to feel like they're a part of this community, that they're able to have this safe haven where they can reach out for information, for education, which is huge. A lot of our members knew nothing about running, nothing about nutrition, nothing about even how to deal with health issues that they had, whether it was diabetes or high blood pressure. So they feel like they now have this community where they feel safe. We have members who say, you know what, I didn't even feel comfortable asking my doctor that question, but I go to your Facebook page and I post and I get, not necessarily medical advice, but I'm getting real life advice from other Black women who may be going through the same thing as me. As I mentioned, this online presence is probably the greatest tool that we have in helping to create change in our community. So what I hope to talk about more on the panel today is really the ability to use social media and digital properties to really create change in our community, especially when it comes to our health.
Thank you very much. Black Girls Run. I even got one of those emails.
Oh, nice.
I was so impressed. Our last panelist is Dr. Keon Gilbert, if you'll start making your way here. And Keon comes to us from the St. Louis, excuse me, let me brag on him while you have slides, Dr. Gilbert, while he's doing that. Dr. Keon Gilbert investigates the intersection of racial identity, racial socialization, and structural racism as an important yet unexplored social determinant of African American men's health across the life course. He's one of the few African American professors, scholars in these predominantly white institutions. At his institution, I'm looking here, University, where are you?
St. Louis University.
St. Louis University. People, you know where that is? And I'm gonna embarrass him just for a moment here. I've known Keon since he was a doctoral student. And so it gives me great, great pleasure to read breaking news on Dr. Keon Gilbert. Listen carefully. Shh. Dear Dr. Gilbert, it gives me great pleasure to inform you that the University Committee on Academic Rank and Tenure has recommended you to be advanced to the rank of Associate Professor with tenure effective July 1st, 2016. Woo! Yes. With the authorization of the President of the University, I have approved and recommended this to the committee. Congratulations. It shows you it can work, people. Follow your dreams. Dr. Gilbert.
All righty. Thank you very much. I'm going to try to compose myself here. So I'm going to talk to you a little bit about some of the work that I do around health disparities, health inequalities, and in particular with African American men. So this idea, we had some of this conversation earlier about sort of some of the differences between structural inequality and the role of individual health behavior. And from this model, you can see that achieving individual behavior change or individual responses is quite challenging when we take into account the social environment, the physical environment, one's genetic endowment, disease progression, sources of wealth, social capital. All of these various factors sort of contribute to one's ability to make certain kinds of decisions. And so in some of the work that I try to do around Black men's health, I've been fascinated by this trend that we see that Black men's health has lagged behind so many other groups forever, essentially. And why have we not paid particular attention to this particular issue? We've done a lot around disparities, a lot around inequalities and social determinants, but why this particular group does it matter so much? When we look at life expectancy is certainly lower, as well as access to health insurance and healthcare coverage. And when we look at mortality from certain chronic diseases, we'll see that it's exponentially higher as compared to other groups. 200% more likely to die from diabetes or prostate cancer, 60% more likely from stroke, and 30% more likely from heart diseases. And also, 3.8 million Black men who are eligible lack health insurance. So when we think about structural causes or structural inequalities, these are the things that I'm particularly concerned about. And so one of the things that's important to remember is that there's no single factor, no one factor that contributes to physical and mental health outcomes that we see in all groups, but in particular as it relates to African American men. And these small differences begin to accumulate over time. And so I have 4 particular frameworks that I've been trying to integrate into my work and that will continue my work henceforth. And one of them is environmental affordances. And so when earlier, one of the first slides I showed was this idea of individual health being very complex, and it sort of taking into account both the social and the physical environment. And when we think about those spaces where we interact, in particular for Black men, how that has a negative effect on their health and their health decisions and coping behaviors. Secondly, when we think about life course perspectives or life course theories that many other people have talked about, we think about the accumulation of these effects again over time. Frederick Douglass said that it's easier to build strong children than it is to repair broken men. And so we really need to think about how do we structure our environments to make sure that children grow up in healthy places and become healthy adults. Intersectionality, for a sociology crowd like this and social scientists, we're very familiar with the concept of intersectionality and intersectional research. And one of the most important things to think about is how Black men are often criminalized, whereas Black women are sexualized in our communities and in different spaces. And we need to think about how this layered view provides a different way of looking at the social identities of Black men in context-specific spaces. Critical race theory, as it is applied to public health, thinking about different ways that we can provide voice to this particular group in this community in a number of different ways, and I'll show one example of that. So as Dr. Thomas mentioned, I live in St. Louis. Many of you may know it as a suburb of Ferguson. And so when we think about St. Louis in the city itself, this is a prominent area called the Central West End. And the Delmar Divide was a concept sort of identified by the BBC in a documentary a number of years ago that looked at this particular area. And as you can see, one street literally defines and divides inequality in this particular community. And it looks similar like this. So south of Delmar is sort of where more white people live. It's more affluent, all these other things. And north of that line is where you find predominantly African Americans. And when we look sort of at the St. Louis region as a whole, you not only see this high concentration of African Americans, but poverty, but heart disease mortality and cancer mortality. My colleague, Dr. Melody Goodman, who's at WashU, calls this a 3-layered cake that you don't want to eat, right? Or don't want to see or don't want to consume. And so when we think about these patterns overlaying with one another, we then start to see sort of the larger context of why inequality exists and why certain groups fare far worse health outcomes than other groups. In public health, we talk about social determinants, fundamental causes, root causes of health. And when we think about the different communities that we live in, we all want to be in the community that has the healthy tree. We all want the community that has high quality schools, employment opportunities, access to health care, health insurance. But many of our communities are the unhealthy community. And we have to ask the question as to why, and we have to figure out ways that we can begin to engage communities in a number of different ways. And so the context of access, and I put access in quotation marks for a number of reasons. And so when we think about access to healthcare in particular, we think about the insurance card that people actually have to get into the system. And then we have to also think about how people are able to navigate through the system and also the sort of interpersonal interactions. And if we take out patient or we put community, we take Black boy, Black girl, Latino boy, Black male, Black female. And also if we take out healthcare system and replace it with education system, or if we replace it with employment system, we see these same patterns persisting. And the lack of access and the lack of inability for people to navigate through these systems leads to differences, and leads to differences between Blacks and between whites. And it comes down to sort of what's appropriate, how the systems actually operate within themselves, and the level of discrimination that occurs within these spaces and within these institutions that actually lead to the differences that we see. And part of my work involves community engaged work, or engaging the communities, or community-based participatory research, whatever the term you're most comfortable with or most familiar with. And the idea is that we're trying to reach a level of full participation of communities along with folks like me, like researchers, as well as other folks who are interested in this kind of work and have access to other kinds of resources, to make sure that we really sort of engage people along in a process that ensures that we reach the level of citizen control and not just trying to manipulate communities or what people have often termed as drive-by research. Right? And so we're really concerned with how do we reach this level of citizen control and full participation. And one of the ways that we try to do that is by building the capacity of communities and making sure that we identify not only the deficits but also the assets, and really relying on those assets to ensure that communities are able to identify problems and to mobilize and to actually address those concerns in a concerted way. And so one of the things that I've been able to do, and I did this in North Carolina, is I engaged a group of middle school and high school boys around health and education. And I asked them a number of questions, and so some of it was self-reflective and some of it was about their communities and environments. And one of the things I asked them is, how do they see themselves? And one of the things that they said was, in order to achieve our dreams, we'll have to work hard, be smart, and persevere. With determination, we can achieve our goals, doing what we have to do to get there. This is the way we want to succeed in life. This came from a group of middle school boys in Greensboro, North Carolina. And they identified Kobe as a person who was at the height of his game, the person that was sort of really identifiable as a person of success. And this is sort of what they wanted to achieve towards. And they recognized that it takes some effort within themselves to be able to get there. Also, when I asked them this question about being healthy and what does it mean, a young man talked about being in gangs and having to get out of gangs and having issues in schools and neighborhoods. And when I asked them sort of what does this mean in the larger context of health, they said health are the decisions that you make to keep yourself from harm or danger. Crowds, friends, and women. Whenever you talk to high school boys, women always come up. What do you do to keep yourself healthy? What do you do? What do you put inside your mind? What do you listen to? Health is your lifestyle. How do you live, not just the doctor, but being in danger in your environment is health. This is very closely related to the WHO's definition of health, where it's both individual, structural, and environmental. And when we think about the environment that we're living in today, we have to take note of sort of what's going on. So this is a recent paper that Dr. Ray and I have in the Journal of Urban Health called Why Police Kill Black Males with Impunity. And when we think about the environments and the spaces, again, that black males interact in, we need to get to a place where we can stop asking this question. And one of the ways that we do that is we have to think about our interventions at sort of the broader level, thinking about socioeconomic factors, social structure interventions, and not just individual level interventions that occurred sort of at the top of the pyramid. And I'll stop there and we'll take questions.
Let's give Dr. Gilbert a hand. Oh, by the way, did I say he was my doctoral student? Okay, if you have cards, index cards, raise your hand. They're going to go pick them up. Raise your hands high. But while those cards are being picked up, I'd like to just pose one to the panel. And you may actually have a question you want to ask each other while the cards come up. Let me ask Dr. Ashley, Black Girls Run. Pull that microphone close to you.
Okay.
Black Girls Run. Black Girls Run. When you think about the black girls that you have involved in this program, are they running from something or are they running to something?
Ooh, that's a good question. I definitely think that the women who run in our groups initially were running from something and now they're running to something. So I think initially, even I used to always tell people, I was running from diabetes, which has had a strong hold on my family. I was running from heart disease, which has had a strong hold on my dad's side of the family. I was running from a lot of these health issues that I feel like have plagued our community. But now I think that people in our groups use running as it's such a way to, one, deal with stress, and then secondly, to really say, how do I push my limits? So we have people who've never run a day in their life and they start running with us, and now they're running marathons and half marathons and doing triathlons, and their friends and family are going, whoa, who are you? Who is this new person? Because this is something that we just traditionally did not do. It was something that we weren't even exposed to. So in doing that and challenging themselves in new ways, now they're running and they're saying, how do I challenge myself in other areas of my life? How do I, go after my PhD or, in my career or whatever that looks like. So it's really kind of taking on a positive tone.
Very, very interesting, from running from something to running to something. Do any of the panelists have a question for either of the panelists? Quickly, going once, going twice. Okay, Dr. Richardson, if you started a group called Black Men Run, would they be running from something or to something, and what would it be?
Initially, I guess away from something. But if I were to start one, it would actually be running towards success, resources, what we see as the defining American dream, not in what we know stereotypically know, but for a place where black men could be in a space of peace, a place of safety, a place of not questioning their masculinity, and a place of spirituality.
You know, in my mind, when I think about Black Girls Run, I literally see them doing their thing and running. But when Dr. Richardson talks about Black Men Run, I see them being chased.
So my comrade here in crime, you know, I sit beside my comrade all the time. So there is an organization called Black Men Run. So, and let me just read it off. Black Men Run supports a wide range of abilities and is open to everyone from first-timers to advanced runners. We strive to promote increased fitness through a culture of running, to encourage health and wellness among African American men by promoting a culture of running and jogging to stay fit, resulting in a healthy brotherhood.
I think it's awesome. But I also want to say some truths, and I want you guys, you're on camera here now. This is a time of truth-telling. When I'm driving through parts of inner city Baltimore or Washington, D.C., that's being gentrified, do you understand what I'm saying? Whole Foods is in, Starbucks is in, but you know it's in transition. And you see white folks running, you know that that's what's happening. It's in transition. It is in transition. I don't know if you see this, the same thing happens in the African American community, but I think that these are life-saving behaviors. Now, I have questions here. There's some more questions. And young man, bring that up here. And so I want you to get down to some of these realities, some of these truths. Come on over here, young man.
So I think a part of what we want to at least put in historical context is that black women, black girls, black men have been running for a really long time and have been the holders of some records of running. So black people running is a black history fact. It is now, there was a period, this dearth that happened post-1960s where we didn't see the promotion of it, especially because of institutional rules governing our public behavior, from swimming pools to our mobility in spaces. And so what's happening with Black Men Running or Black Girl Run is a reclamation rather than an introduction.
I think that, again, when that history gets lost, we fail to realize that's always been part of our history, including biking people, cycling. Major Taylor, the first world velodrome racer, was a black man. And the white racing community honors him, but many in our community don't even know he existed. I want to give voice. I got these questions here, but come on up here, young man. The power is, again, all these narratives. Let's see, I think you may have a question in this stack. I'm going to give you the mic. Introduce yourself.
Hi, my name's Nigel Williams. I currently work in health policy in DC, and I will be a student here in the fall in the School of Public Health with Dr. Thomas.
I didn't know that.
I do now. So one of my questions was, since the implementation of the Affordable Care Act and the increase of coverage all across America, but especially in our communities of color, have we seen any decreases or increases in health factors in relation to those socioeconomic and racial factors that we talk about?
I'll say something about that. So A lot of our data lags behind real time. So we know that the Affordable Care Act is still relatively new, but whenever people have the ability to have things paid for, it frees up their resources. And if we're talking about groups of people who have limited resources, we now have more money to pay for food, to pay for a place to safely exercise, a gym. And there has been studies that have shown that people with more healthcare coverage are able to be compliant with their medications. And compliant with medications means being able to take them, and they're also able to start purchasing some of those foods that we're asking them to eat. So ramen noodles versus eating, a salad, we know which one is more financially attainable, and hopefully with the Health Care Act, we're able to continue to do that.
Very good. And I have questions here. If you're willing to give it in your own voice, just come up here real quick. Let me read one.
Can I comment?
Sure.
Follow up on that really quick?
But
Because
questioners,
I
move
have,
up here.
I have something that I found that was really interesting in my work with the Navigator. So if you come into the trauma unit and you don't have all the requisite documents for the Affordable Care Act, and that means your Social Security card, your state-issued ID, your birth certificate, then you are classified as unidentifiable by the ACA Navigator. And in order to determine that you are who you say you are, they have to run your name first through Experian, which will never come up because most young men who come into the hospital that don't have insurance don't have credit. And if your name doesn't come up through Experian, they run your name through the IRS to see if you file taxes. And so if you don't pass either two of those things, then you will leave the hospital without being enrolled. And you have to bring those documents back to the Affordable Care Act Navigator or back to a health exchange in order to be enrolled. And so some of the ways that the Affordable Care Act was even thought out, they didn't really clearly think out the vulnerable populations that they wanted to enroll. And young black men that have been disenfranchised and estranged from the healthcare system often won't enroll because they lack those documents even when they're coming into the ED. And so that's one of the things that we really need to make clear is that the Affordable Care Act, I don't think, was designed in many ways and thought about for vulnerable populations.
Well, you kind of give the benefit of the doubt, Dr. Richardson, but maybe it was designed to do exactly what you just described, to deny the very people who are most vulnerable. I have another questioner here. Come on up and introduce yourself. Take the mic.
Hi, my name is Caress. I just want to thank you, first of all, for coming out today. It's really awesome hearing all the wonderful work that you all are doing. But I have a question for the two men on the end. Too often conversations around violence and trauma are centered around black men. And so I'm wondering why some of this work isn't ever really centered or talked about or put as much efforts in and research when it comes to black women and the experiences that black women have. Black women are just as much criminalized by law enforcement and just as much experience, whether it be sexual violence or domestic violence, have experiences of trauma. So I'm wondering where the resources for women in this research.
Very good.
So that's a really good question. This summer, or last summer, 2015, while I was conducting my research with the Navigator at University of Maryland, Shock Trauma in Baltimore, she mentioned repeatedly to me, Dr. Richardson, you need to focus on women. And I think primarily because my focus has been on men and health risk behaviors among men, I haven't taken the time out to really focus on women, but clearly we were seeing experiencing in our trauma unit a number of women coming in, and it wasn't for domestic violence either. This was interpersonal. So these were women that were coming in that were victims of gunshot wounds, stabbings, and assaults. And I think that's kind of the invisible population that we have often neglected and we need to include in our research. And so even on our violence intervention program, while we focus on men, the psychosocial services are not strictly for men. And so that's one of the things I want to make clear, but clearly there's a need for it. We need to have more researchers that are focusing on it. I need to focus on it, and we need to be cognizant of it.
Here's a question on the card. Community indicators are vital, but how can we get the black community involved in those issues at the national policy level? Without black voices, structural racism will continue to persist. Any comment?
It's very interesting that that's one of the questions for today. We've been having sort of this conversation over the last couple of days, actually, some of us who are here on the panel, about sort of how people actually get to the table and what's the responsibility when you're at the table. Also, even how you get invited to participate at the table in these kinds of conversations and these being part of these dialogues. And it's really important for those who see themselves as activists and advocates to not only show up, but to also represent, and then to be able to bring other people along with them, to make sure that it's not just sort of one voice, it's polyvocal, to ensure that the representation of the interest of that particular group is really met. Because sometimes what does happen, and this is one of the things that happens with even that latter participation that I showed, is that sometimes people who are seen as leaders or seen as the main voice often sort of get singled out, and they become sort of exceptionalized in a number of different ways. And we have to work against that kind of strategy to ensure that everyone is represented and is able to have their issues and concerns voiced. And that's really something that's important as we look at, you know, the history of student activism on college campuses and universities around the country, but also what's going on in the communities outside of these college campuses and in the larger community as well, and also making sure that it's multi-generational. So one of the things that I think was really apparent with the movement of Black Lives Matter is that, and this happened in St. Louis in particular, is that this moment came in 2014 where the older sort of Black established leaders wanted to sort of swoop in and take control. And the young people said no. They probably said some other things and said it differently that I can say on
Hell
camera
no.
here. They said hell no, absolutely. And so there was a clash. And when you have those kinds of clashes, you know, especially around, you know, age and gender and class lines, they become real tensions that have to be managed and have to be resolved in other kinds of ways. And so we have to sort of really think from the beginning, how do we present a polyvocal choir to some extent to make sure that everyone is represented?
So can I just add something
Sure.
to that about the policy process? Because I do think that, especially in academic spaces, there's a misunderstanding about what policy is. So policies start through conversations. And for those of us who are trained academics, we are often forced in that last paragraph of our paper to write about recommendations. And those are usually lofty ideals that no one intends to accomplish, but we say one policy recommendation is that we should all have a higher minimum wage or something like that, or that we should eradicate health inequality. Those are not the places where policy are made. So as a person who spends way too much time with people who do actually codify rules that then become rules that govern the lives of more than 20 people, I think that it starts as simple as the thoughtful inquiry into what goes into that last paragraph. It starts with educating our young people, as in the particular case that I showed around Marley Dias, which is how do you change even a school policy about what gets read? That's a part of a policy that makes its way up. So we think that we need to start in DC in order for policies to get affected, but a lot of these underground policies are really important. If we think about Abigail Sewell's work about frontline workers' actions become de facto policies, and how we want to affect frontline workers is not going to be through the rule first. If you think even about Black Girls Run, how their presence in parks might affect what park policies are about lighting, right? So all of these things, I think, for us in the academy, we need to start being much more mindful, even though we're not all in policy schools, about what does it mean to change a rule that governs the lives of more than 20 people. we need to think in this population level way as we think about rules. And when we say policy, perhaps we should start by saying, what are some of the governing rules that negatively impact our well-being that we need to start working to undo? And those happen in informal groupings before they become formal groups, even in the sense that we think about Black Lives Matters movement. They start informally.
Can I say one more thing?
Yes.
Just really quickly, Janice mentioned something very important in terms of even what we do here in academic spaces, and what I'm going to suggest is often frowned upon sometimes. And it's the idea that we write papers and they exist in journals, online, or in libraries. But if you even take a few moments to share your work with local news media, with policymakers, that may have some real impact in terms of how they actually think about particular issues. And it's something that we don't do enough, that we should do more of, and we should act, and I'm not saying that we have to get academic credit for it or anything like that,
We should.
but it should be valued. I can understand, yeah, you're right, but it also should be valued and encouraged as well.
And part of it is in the institutions, what projects, because you're competing with all kind of things on campus, get that nod that we're going to let university public relations promote your stuff. And I would just say to Dr. Richardson, the work that you did, I don't know if you ever imagined it would end up on NPR, but the fact that it did went to millions of people all across this country to reframe this whole notion of Black men and trauma. So extremely important that we give public voice to our scholarship. Yes, sir.
Hello, my name is Damon St. Thomas. I'm a senior here at University of Maryland, majoring in sociology. My question is pertaining to an element of the Black experience that I think is addressed beautifully by the intersection of structural racism and of health. And one thing I've noticed, whether it's in these presentations, the news media, or society overall, is that many of the issues pertaining to the violence among Black men or in the Black community in general, issues of health are primarily addressed from a macro perspective in that this is what the dominant majority group or the white America does to the Black community. For myself, growing up in inner city Baltimore, all of the violence I've seen, the penetrative, the violence, the stabbing, shooting, have been done Black on Black crime. I was robbed at gunpoint, by a Black man. My brother has been robbed and shot at and stabbed and has done that to other people, to other Black people. And so I guess my question is, how do you address that without culturally being insensitive or insulting? Because I know growing up, in Baltimore, if speaking health-wise, not only do we, maybe promote our health by spending hours at the basketball court, because culturally Black people are supposed to play basketball or be physically active, but also I think of the foods that are just unhealthy, the chitlins and the other, stereotypical things, but are real issues. And what I've noticed is that in trying to engage people in my community about these issues about the Black on Black violence or engaging in health practices that are unhealthy, anything that diverges from that normal social conditioning of the Black experience is seeing as, not being one of us as being white. So what's, I guess, your thoughts on being able to address that, intrinsically from within the Black community?
Give this brother a hand. Give him a hand. That's the kind of students that we have here at the University of Maryland. And now you know there's a pathway to the doctorate for you, brother. All right, go ahead.
Yeah, I'll take a step at that first. Speaking from Black Girls Run in our experience, one thing that we've noticed is, you initially do kind of get that pushback from people and saying, maybe they say something like, that's something that white people do, or that's not what we do, or that's not how we handle stress, that's not, something that we do, and especially in endurance sports. I mean, we've traditionally been track stars, basketball players. I grew up playing soccer, and here in the U.S., that was not a big sport for African-American kids. So, we definitely get that pushback, but where we feel like we've been able to create the greatest amount of change is really coming from a place of love. It's coming from a place of not kind of trying to create fear, because people don't really respond to that, but really trying to come from a place of love and showing people that there is a better way to live. And you do that best by example. So it's like, I lived in Harlem, and I would run through the streets of Harlem, which was back then predominantly Black. And people would, not so much now, but people would literally stop me and say, "What are you doing?" And so I would take that time to tell them, "I'm running." They would say, "Well, why are you running? You don't need to lose weight, do you?" And I'd say, "No, this is for my fitness. This is for me to just deal with stress." So it's really explaining people and coming again from that place of, here's how I'm living, here's my example. You can take it for what it's worth. I'm not trying to press this on you. I'm not trying to instill a fear of, oh, you're going to die from a heart attack, you're going to be diabetic, all of those things, because we already know that. So I think it's just really, really hand-holding, and even with our groups, we have to initially, we call it a lot of hand-holding with our women, but it's really saying, yeah, you know what, here's my phone number, call me, I can talk to you about running. I know you're not gonna pass out on this run. No, I'm not gonna leave you. No, if you do, there are ways to deal with diabetes that aren't always with medication. So really being able to create a safe space for people to also have those discussions. We didn't realize, Tony and I didn't realize that, you know, Black people didn't feel, you know, like there was a space for them to go and talk about their health. We also realized that we did a project with United Healthcare, Generations of Health, and we don't even talk about the issues that we have in our family. So knowing that your grandmother is diabetic, knowing that you're at high risk for heart disease, we don't even have those conversations. And so it's just about creating that safe space for that to happen.
You know, some people may remember in the newspaper where there was this issue with Black kids in school. If they got good grades, they were called white, and that was like a negative thing. And so to hear you, in the context of healthy lifestyles, have that same pushback is really concerning. So as we look in magazines and we see commercials, we need to see more diversity. And your next man, want to come up here?
What can I cut in real quick? Because I got to address that.
Okay, go ahead.
One of the things that I think is really problematic is that term, like black on black crime, because most crimes are committed by people who are in close proximity of them. And so interracial crimes occur all the time. No one ever says in the context of white on white crime. The majority of crimes that are committed are white.
Keep it real.
Against whites are committed by other whites because they live in close proximity of other whites. So to use that term is really a misnomer. It's very inaccurate. And one of the other things I want to make a point of is that, yes, you are from Baltimore. The neighborhood that Freddie Gray lived in, you can do the numbers. That neighborhood was a victim of structural violence well before Freddie Gray arrived. He was dying a slow death from birth. 3% of the people that are in state prisons in Maryland come from that one neighborhood. So $17 million spent on 72 blocks. But I want you to make clear as you move ahead, and be careful of using that term, because the proximity of where people live relative to who they commit crimes against is how crime is played out.
There are a few people who look like the panel and us, where our one act, our one action ripples to the whole group. Yet we just had a mass shooting, 8 people in a family, multiple shots in Ohio, rural Ohio, all white. That's not going to ripple to every white person.
But I do think you have embedded, you said several things, and I just want to unpack a couple of them because I think that they are related. So what I heard in your comment was, what happens when we visibly see Black people engaging in activities or actions that are negative for them or for the approximate or close other Black person? How can we then actually blame white people for that? I feel like that's actually the real, that's what the real thing is. So when Black people eat fried chicken, are we gonna blame white people for it? When Black people shoot another Black person, how is this the white man's fault, right? I mean, that's a good question, by the way. I think that these are the kinds of questions that are appropriate, especially if you're a sociology major. And they're also the kinds of questions I think everyday people ask and are interested in the answer is. So no, I don't think you can simply just blame white people. But let me tell you why you can really blame the institutions that uphold the system that have been historically managed, many of whom are whites. But you can blame some good Black people too.
Okay, do
right?
it.
Because I think that that's where it's different. When we When we place these things in historical context and we come out of a United States that has largely been constructed through white supremacy, and the architects of those are actually people whose bodies are white, then we find ourselves in this place. But now the people who uphold white supremacy aren't all white.
Tell the
right?
truth. Tell the
and
truth.
so, given that that's the situation, it would be inappropriate at this historical moment to blame white people for everything. But there was a historical time where that was a truth. So now we need to think about these terminologies and the importance of adding to our lexicons terms like white supremacy that still lives, but now lives in the body of those who are not just white. And we can, in fact, one of the things that I say, if you do see people in neighborhoods that are highly segregated, high levels of economic inequality, high levels of crime, and they're eating on some fried chicken, they are eating on some racism. That's real talk, right? The other thing is that when we look in the faces of people who may share our hue and our historical condition, and we choose to harm them, right, for reasons that are not clear, like they didn't actually take our money or our car or anything else, we can in fact blame that on a historical perspective of dislike for those who would look and reflect us. So we can actually blame white supremacy, but we can't actually just blame white people.
All right. Give her a hand. Come on up, gentlemen. Come on. Okay, you got the mic. Introduce yourself.
Still blown away by that answer. That was fantastic. I'm Carrie Lee Riley. First thing I have to say, as someone who's been doing a PhD for quite some time, I think we really do need to give it up for the folks who got tenure. And there's another gentleman who was here also who recently, I think he's gone, but I really have to go there. And as someone who's been through the tenure process, that was trauma. My question, something that hasn't come up here is fatherlessness. And, throughout history, this has been the #1 issue that has been raised. And obviously, with slavery, separating the families and so forth, it's come negatively with the Moynihan Report and the tangle of pathology and blaming black women. The fact is, it is a fact. And I've seen black feminists say that it's a misogynist, sexist thing to say, and that black women are equally capable of raising black boys and black men. So I'd like to hear from everybody about this whole issue of fatherlessness. How big of an issue is it? Is it being overproduced, et cetera?
Thank you very much. Anyone want to take that? Just jump right in there.
So first, I want to say that all the data has supported that non-custodial black fathers have the highest level of engagement with their kids.
No, break that down for some of us.
So for black fathers that don't live in their homes with their children, they have the highest level of participation and engagement with their children.
They actually are involved with their kids.
Yes. So please don't buy into that myth. Don't believe that hype. That's hype.
See how we need some more scholars to get the real story out?
The other thing is that we don't, even in light of that, we don't take full account of other black men who are social fathers.
Okay. Explain that. Break that down.
Well, there are various forms of fatherhood. There are various forms of black fatherhood. They're not necessarily biological, and they're not necessarily stepfathers. And so they could be uncles, they could be grandfathers, they could be the old head in your neighborhood. There are many different forms, coaches. There are many different forms of black fatherhood that we fail to acknowledge because we have unique ways in the African American community based on structural violence of creating families. And so I think we have to acknowledge that, and we have to acknowledge that there are other men that come in forms of fatherhood that traditionally the research and the literature has failed to acknowledge, because when we study black people, that we automatically ask the question, is your father in the home? And we immediately assume not. We check off the box and we move on. So I don't know if I've answered the question.
Well, you got the conversation started, and that's what this is all about. Now, I got to hear from some of the ladies up there on this issue. Come on, one of you take the mic, and somebody else step up here. You don't have to have. You're next. You're gonna come up here with me.
I think that he wanted to hear from the other panelists. Clearly, this is an issue I spend way too much time thinking and talking about. I do think, again...
Get close to the mic.
I think Joseph has really identified one of the places where, again, the Moynihan Report, policymaking through conversations that then becomes codified and becomes regulatory measures, has taken place, right? So Moynihan decided that the construction of our family needed to mimic the constructions of white family, not paying any attention to the historical disadvantage and reshaping that America did for those of us who were artificially emigrated to the United States. So I think that we need to think not only about the fact that our communities still have healthy, loving, caring black men who father our children, but we need to think about two other actors who I would add in there, not just men who are of age who would be fathers, but what does it mean if you have brother-like figures under your household? So a household is, a composite of, it's not like a family, but it's a composite of all the people who live, and given that we still live communal style, that brothers can also play this role that biological fathers cannot. The other piece is educational institutions in general, primarily educational systems, have always been a way of helping to advance or deter black mobility. And I think it is the same in the caring space. How many of, and you see it in popular narratives of athletes talk about the role of their coaches, the role of their teachers in being healthy role models. So I do think, again, we get trapped in thinking that the model that is operative for white families is the measure of healthiness. And when black families don't replicate that, then that is a model of unhealthiness. And we need a new picture, a new framework, and a new square. Maybe we need an oblong.
Well, we have just started that conversation. Yes, ma'am, introduce yourself.
Yes, my name is Furuq Saadatman. I'm from Howard University. Right now we have an ongoing study recruiting 700 African American 18 to 25 in Washington area. The results are really great. I will share them with you. But first I wanted to let you know about the 1,000 book and the experience I had with my daughter. At age 3 when I was reading English book, I'm from Iran, so I would read Farsi or English. In Farsi we don't have gender, so you don't know who you're talking. But when I was reading it in English, she kept saying, and it was a he, she kept telling me, she, her. So she would correct me all the time when I was reading it. She did not see herself. So I can see that, how important it is in the United States, being an African-American girl. And Dr. Richardson, in terms of violence, that's our research, exposure to violence in DC. So there is a difference from our preliminary study. In our analysis, there is exposure to violence between male and female. Of course, community violence is much more severe among men, and personal violence, especially abuse and raped as children in women, is very different. So there are two different kind of exposure to violence. But when we're looking at it, in general, exposure to violence is so important in mood disorders, so-called, in sleep habits, everything that impacts us as human beings. And you indicated exposure to abuses, how that is important in every health outcome, diabetes, whether you have asthma or not, and we know how that is prevalent in terms of also drug use. There is a recent theory more and more that drug is not really being hooked on. That theory is so old, and it came out of a mice in a cage that was given a sugar or a morphine, no other option, so the mice would go always to the morphine. But when they built a park for the mice, they did not choose the heroin. So when you have no connection, is about connection. It's not about you're hooked on drug, because a lot of people have injuries, they come out of hospital, they don't want any more drugs. So I just wanted to commend your research, and hopefully we can collaborate. Thank you.
Very, very good.
Thank
so you
you.
see how it can be embedded in the language, in our
No,
language.
I definitely appreciate the comments, and I think when we engage in our interviews, because we have to build trust and rapport, we're often the first people that men express that they've been abused at some point in their lives, and that's one of the reasons why we think the mental health component is so important, because we ultimately find out, and 100%, I wouldn't say 90, 95, 100% of the cases, guys will reveal to us over time that something has happened tragically and traumatically in their lives that they've never discussed with anyone. And so we find that really among the trauma recidivists, and those are guys who have been hospitalized 2 or more times. And so we've had one young guy who was hospitalized 4 times. He was shot on 4 different occasions. And one of the things that he dealt with, his trauma, was he was a resident in New Orleans during Katrina. And he never had expressed how it traumatized him until we met him, and he was moved here. And so these are just things that occur as a continuum across the life course, which is why I emphasize the birth of a nation, because our trauma there's been a continuum of it. It just didn't start when this person was injured out in the street and came to the hospital. It's been a continuum of it, and much of it has been structural violence, and that resulted in interpersonal violence and trauma.
Now, this question is for Dr. Ashley Hicks and
Sorry to
Dr.
make a
Carr.
comment. Sorry.
Oh, yeah, please. Jump right in there.
So when you brought up mental health, that's one thing I haven't heard us discuss much yet, but it's twofold. We know that in the African American community, a lot of times we try to minimize our mental health issues. But in general, mental health professionals, a lot of them do not even take health insurance. A lot of them are cash only. And then the ones that do take health insurance are far and few in between. When you do have people that come in with a mental health condition, a lot of times it's conditions that may be obesity, diabetes, or someone that is especially dealing with people who are recently incarcerated. A lot of times they may or may not have been receiving mental health services when they were incarcerated, and when they come out into the community cannot get services at all. So then you're leaving people without treatment, and the main treatment for PTSD, post-traumatic stress disorder, is therapy. So it's not like as a primary care physician I can give them some pills. Right. They have to be in a place where they have access to a therapist, and the place where we have most studies on that are with veterans, and the VA system has tweaked that very well in giving people group therapy and giving them therapists that they always have access to. But we know that PTSD is something major in our community. We don't have any of that.
Well, I was impressed, Dr. Richardson, with your narratives to realize that there was something about your qualitative interviews that in and of itself was therapeutic, without calling it, oh, we're in a therapy session. You know what I mean? Mm-hmm. Yes, ma'am. And introduce yourself.
Hi, everyone. I'm Grace Snodgrass. I'm a Maryland alum, and I've been working in education in New York and LA for the past decade. And school systems. 2006.
What school?
College of Journalism and BSOS, government and journalism major. But have been at home in education for a decade. And we have been talking about a lot of things today that I imagine rely a lot on conversation, on education, on getting to people. And in schools, we got them, right? So we have kids, and not only kids, but families. And from my own personal experience, like to wit, we have free and reduced lunch programs, which is important, although that's its own issue because kids often don't want that. That's not what they eat. There's not enough positive buildup of even that. But and then like the presidential fitness test. But beyond that, there's not a lot I've seen system-wide to address student health, let alone community and family health. And in your own research areas and what you've seen, I'm wondering what you think can and should be done in as far as policies system-wide, or what you've seen that's working to improve health outcomes for kids and families.
Very good. Anyone want to take that?
So the Robert Wood Johnson Foundation has what has shown to be really highly replicable research around just on movement. They have a thing called 10-minute recess. And what we know happened from the early, the preliminary studies around children's movement is that though we have a requirement that children and all of us should move 60 minutes of rigorous activity 7 days a week, we know that even when children get recess, there will be some that choose to stand against the wall. There are others that will play much more aggressively, et cetera, but it also can it ends up being, I think on average, they say about 9 minutes of movement for a 30-minute recess. So the pilot that Robert Wood Johnson has done in several different places through their Active Living research is 10-minute recess, which is actually done in collaboration in the classroom with the teacher. And that assures that it's actually 10 minutes of movement. And we know the basic research about what happens in terms of the brain if children are actually moving. So we know that they have greater learning capacity, at least within the next half an hour afterwards. So all of the preliminary tests suggest that 10-minute recess, if adopted across especially schools that have free and reduced lunch, would actually see an increase in mobility and an increase in overall health and well-being, and an increase in academic achievement.
Very good. Now, this question is directed to Dr. Ashley Hicks and Dr. Cosby, but it's broad enough for any of you, but they can start. What does the academic community need to know and do better? Let's recognize, people, this is a rare thing you're witnessing here, okay? A panel of experts looking like these folks. Look at this, okay? So let's not think this is the norm. What do we need to know and do better so that we have more of this, not less of it?
Okay, so just to clarify, I'm not a PhD, but from somebody who's just grown a grassroots movement, from my perspective, I think that one thing could be definitely more collaboration. I think that when, I think someone said it earlier, with academics, you have great research, a great understanding of the issues, and people like myself are on the ground implementing that. So it's just having those conversations to know what we could be implementing more of. I think that's just the biggest thing that could be done. I don't know.
I think a lot of the discussions, especially when we talked about policy making, a lot of these things are just limited by funds. And especially as a physician, we are really pushing towards the patient-centered medical home model. And that's just a concept where if you come into your doctor's office, you have a social worker, you have a pharmacist, you have a pharmacy, and you have a nurse who can explain to you about your diabetes. And all those things are great, but there is zero money to do any of it. And we've had a lot of studies that show how those models play out and serve patients, especially if they have low health literacy. But everywhere where we need these things, we do not have any funds. Whether you're working at a nonprofit or a for-profit, it is just not feasible. And with health insurance, that's pretty much the rate limiting factor. And looking at how, who is lobbying for what? Pharmaceuticals and health insurance, they pretty much run everything.
Okay. This is an interesting question. It has to do with the intersectionality. LGBT black men have some of the highest rates of being victims of violence within the black community. What kind of interventions do we have at that level?
We have little to no interventions. Even if we were to think about the LGBTQI community that is established, that identifies and is aligned with the AIDS movement, we are still struggling with what to do with LGBTQI youth, right? We are struggling because we have adopted in our community the idea that we could afford to be as patriarchal and as sexist as the white community, right? Because if we're trying to mimic, because whiteness means healthy, good, and prosperous, we might as well take on some of these other things like patriarchy and sexism, even though we can't afford it. So I think that all that we know, our understanding about LGBTQI individuals in our community is limited, is still covered with fear. It is still covered with notions of what is right and wrong. And our researchers have not, their work haven't been funded in this way, and therefore it is very difficult to get real, true knowledge about how we understand before we can even begin to address. It may not be the last bastion of problems in social science research, but it's so wholly inadequate that the idea, like, we can't conjure up any real sentences to say about what is happening because there's no mainstream research on LGBTQI individuals.
What solutions do you propose for those people, some may be in this room, living in these environments that you have defined throughout this day as toxic? If I can't move, I gotta live there. What do I do?
That's where the party's at. Okay, so I don't want to keep talking, but this is the reality, and that's the perfect question. I think this is where we should devote all of our attention anyways. People are not gonna move. People we had the MTO study where Move into Opportunity study, people don't move. Even if they move, they're coming right back. People like to live where they like to live, around who they like to live with. In general, we have very low mobility. We have a lot of transiency within spaces, right? So people get evicted, they might move to a place. But in general, they stay geographically bound. So for us at the Grassroots Community Foundation, for me, who I am, a part of it is teaching people how to change the systems that are currently organizing their lives. And one of the core ways to change the systems in your local neighborhood, your local school, your local zip code, is to form coalitions. Whether the coalitions begin with run-in, whether they begin with shared trauma, whether they begin in your PTA meeting, is that we have to get really concerted, those of us who are invested in the well-being of communities, to try to teach people how to join with other people. And that joining doesn't have to start large, but it must be intentional and it must have an action goal. So if you all live in this really bad neighborhood and you don't like 97 things, let's start with one thing that you would like to undo, and together try to work on that, because the process of engaging in any social action is twofold. The win is twofold. For the individual, it increases self-efficacy. For the group, it increases cohesion, and for the potential benefit is that it transforms systems. So it's through acting, but a solo act is not going to yield those rewards. It might yield one or two people feeling individually good, but it's about building these coalitions so that they can grow.
I have a card that says, I don't have a question, but I have a comment about the symposium. Okay, stay right there. Not yet, but I want to make sure I knew who that was. Okay, it's coming up. So I want you to step back just a bit, and any of you can come in now, because I was in another session right across the hall where a person got up, it was an urban planner, and was going on and on about this great program called Move to Opportunity. So we'll take some black folk in the inner city of Baltimore, and we're actually going to move you to the suburbs, all right? We're going to move you to that neighborhood, Dr. Gilbert, where the life expectancy is higher. And someone next to me whispered to me, and they said, well, you know what? Some of those people move back to the hood. They get to live out there with all the Starbucks and all the nice things and all the resources and parks, and then they move back to the hood. Now, nobody pushed back over there in that other room. Do you understand why a black person who finally got free, I'm setting it up, you don't have to agree, I got the freedom now to live over here in the suburbs with all these good things, I'm going to move back to the inner city. Why? Move to Opportunity. That's the name of the program, and your tax dollars are paying for it.
Well, we know the findings. The findings are public. So when the Move into Opportunity demonstration started, we had two core findings. One, black boys were more likely to get arrested in these new spaces. And two, black girls got really fat.
Got really what?
Fat. They got really sick. So what happened was they internalized, black girls, as most women of the research tells us, have internalized, right? We don't sleep, we don't open our bills, we get sad, etc. Black boys were now made visible and hyper-surveilled, right? Move Into Opportunity had several other failures in it. But when we, I think a part of what is generally missing in the conversation, the housing conversations about mixed housing and how social networks work, is that their lot is lost. It's not just simply the connection, it's about also the resources. When you live with people who you have close relationships with, if you run out of food, if you need somebody to take care of your child, if you need a ride to work, if something happens, is that those resources, those kind of unmeasured informal resources, did not travel with them just because they got a more aesthetically pleasing environment. And therefore, as we think about these social experiments, that Move Into Opportunity was a dumb idea from the beginning, but it was exacerbated by the fact that people put dollars behind it.
Big dollars.
Really big dollars. And also, it did not account for what social cohesion really mean. I think that there continues to be this misunderstanding because of the popular error that Black people can't seem to get along with each other. That we should in fact break up, that if we were integrated more again with whites, it's not just economic integration, but to integrate it more again with whites, we'd just be in a better place. But there's no supportive evidence for that. In fact, MTO, thankfully, failed so miserably that it caused us to rethink that perhaps what we should do is think about investing in those local neighborhoods and trying to get people to come together and form social actions that would actually benefit the neighborhood and the places that they live.
Yeah, like running clubs.
There was a really good film, which I show my class, documentary shot by Sudhir Venkatesh called Dislocation. And he documented families that were being pushed out of Robert Taylor homes because they were knocking them down. And it was interesting because at the end of the documentary, he asked every single person in that documentary, if I could give you a key to a new home or you could move back to Robert Taylor, which one would you pick? And all of them consistently said Robert Taylor. And the primary reason was what Janice alluded to, is that they lost those social connections and they lost that social support that they had in their neighborhoods. And so while we're socially engineering the lives of others, which are really not thinking about the social connections that they're losing, this is what's actually really happening, is that you're dislocating people from the social support and social networks that they've had and that they're accustomed to and that are really nurturing. And that's one thing that we tend not to think about when we think about aesthetics, is that we can move you to this environment, but substantively, what does that mean for my life, qualitatively?
I was just speaking 35 miles up the road in Baltimore, where some people live in neighborhoods with boarded up buildings, okay? Here you have someone living in the building, and next, the whole rest of the street is boarded up. And then they had the CBS News reporter walking the streets and interviewing a woman who said, we've been lobbying for these buildings to be torn down. And finally, the bulldozers had showed up, and they were tearing them down, and this person was celebrating, the news reporter and the person. Then the news reporter interviewed a Black man, and he saw the demolition totally differently. He said, they're finally moving us out. By demolishing these homes, now we have no place to come back to. The same thing through two different lenses, happening 35 miles up the road and maybe even in parts of the District of Columbia. Some see progress, and others see institutional oppression.
Yeah, I mean, to your point, that's kind of the story in Atlanta as well. But you have the added layer of, you're relocating people to where they completely don't have access to transportation because we don't have a sophisticated transportation system. And my husband and I, when we moved back to Atlanta, we're in the heart of the city, and we see actively the people in our neighborhood who are pushing and lobbying to push those people out. And so when people ask us about having Black Girls Run groups in some of the neighborhoods where they are being relocated to, the challenge is it's a new area. Also having, there's not sidewalks they're moving them way out of the city. There's no sidewalks. They don't have transportation to get to the heart of the city where we have a lot of our group runs. So it becomes a greater challenge for us. So even to the panel, any ideas that you guys have for a grassroots organization, it's and what we could do, would love to hear, because it seems like when you're fighting the price of land now in Atlanta is so high inside the city. That's the number one challenge. There's nothing that we could do about it. And then fighting, what I consider racism, in that they don't want to expand transportation because, whites in the north part of the city, or traditionally have lived in the north part of the city, don't want those people having access to their neighborhoods. What was that?
Like Georgetown.
Oh yeah,
She was whispering.
Well, so
But
I'm sure
she's
that
right.
I'm sure that issue happens in other places, but it's just to see it live, kind of in action, to see the neighborhood that's adjacent to where I live now. That now you have to buy, spend upwards of $1 million for a home, and it was traditionally black, and to see them pushing the people out is kind of disheartening in many ways. But you're on the other side of it, not really knowing truly what to do.
It's internal colonization, basically.
So, racism in sickness and in health has launched a conversation. Hopefully that will continue. And you're going to help us continue that conversation. Come on up, and Dr., you're going to be our last questioner, next to last, but introduce yourself.
I'm Sarah Stevens. I'm Sarah Stevens. I'm a sociology junior here. I have a question for Dr. Richardson. We know that PTSD doesn't just affect the person who has it.
Right.
So I'm wondering what resources there might be for members of the family or friends of the people who are in your program to help support them, to help understand what their family member is going through, and how that sort of support could help the community as a whole.
So it's a good question. Last year, I submitted a patient-centered outcome research institute grant, PCORI, which is the research arm for the ACA. And it was specifically to kind of address that point of how caregivers are experiencing trauma related to the person who they loved who was injured. I didn't get the grant, but fortunately, UMD School of Pharmacy has what's called a Patients Program Seed Grant. And this year I was awarded a seed grant to conduct interviews with the caregivers of young men who have been injured, and to get their input on what kind of stressors, what kind of trauma that they're experiencing, so we can add that to the intervention. And so right now we really don't have great data on what kind of stressors caregivers experience. And so there's a lot of data on survivors of homicide and examining in-depth the experiences of particularly mothers who have experienced the death of their sons via homicide. But we haven't done much on young men who have survived a violent injury and live within that household. And particularly when you're dealing with someone that's been injured multiple times and they're living within that household. So that parent has to go through that trauma again and again and again. And every time that person steps out of the home, you can imagine the kind of trauma that parent or caregiver experiences, wondering whether that person will make it home safely. And so this summer, what I plan to do is conduct focus groups with the caregivers of young men to determine what are their challenges and what they would like to see as a positive outcome, not only for the young person that was injured, but also for themselves.
Not only with mental health, but caregivers physically, especially of patients who recently or at any point dealt with a trauma, have a lot on their plate. People who are victims of gunshot wounds do have a lot of spinal traumas where they may be paralyzed. So if we're dealing with an 18 or 19-year-old male who's in a wheelchair, it's almost the same level of care that we would need to give to an 80-year-old man who is in a wheelchair because of a stroke. But yet you're going to have to give that care for the next 50 years. And what is that going to do for a mother who is in this neighborhood, who is probably also taking care of other siblings in this communal living and has limited income? What is insurance doing to provide a home health aid? What is insurance doing to provide wipes for those people who can't get up and go to the bathroom, wheelchair ramps in these inaccessible homes. So it's a very layered situation that the caregivers have to navigate by themselves. Hopefully, the patient navigators can help these people when they are enrolled in health insurance.
One of the things we had having, this is the last thing, if you look at the documentary, the young man that was featured in it, he didn't have insurance, and his colostomy bag was it was moving towards permanent attachment to his skin. And so his grandmother, who was also featured in the documentary, spent an inordinate amount of time trying to get insurance for him to address it. And so these are all issues that the caregiver has to take on, particularly in spinal injuries, and also just what the trauma that's associated with the violent injury that young person may be going through. That caregiver also has to deal with their mental health issues as well. And so what we're seeing is, and this is the last thing I want to say, is that mass incarceration, we found, was one of the most significant predictors of someone coming back to the hospital if they were previously incarcerated. And so what we've been finding is that some young men also are shifting over to smoking synthetic marijuana, right, because they're on probation or parole. And because it doesn't show up in your typical toxicology test when you're under mandatory probation or parole, they're shifting over to and smoking it and not really knowing what they're smoking at all. And so that's another issue that a caregiver has to deal with, is that the substance use issues as well. So there are a multitude of issues going on, and hopefully, our research will be used to inform some of the interventions to address it.
Now, I want to thank everyone who gave questions, and I want to ask the organizers to make sure that these get written up in a response. I'm not turning the mic over to you yet. I got one more person, but I know you're ready, and I want to give you your propers when I bring you back up here. But, and we talked about some, congratulating people who made it over the other side in this whole promotion tenure thing. But I want to ask the godfather here, Dr. Tony Whitehead, who had a question. Come on, Tony. Who helped lead the way, break down doors so the rest of us could be here. Go ahead, brother.
My name is Tony Whitehead, retired professor emeritus in anthropology. And this morning, when I was trying to decide whether to come over here and to drive to take the metro from Reston, I said, I can't do this. I'm retired, I'm trying to write, etc. But I wanted to say I thought this was a great seminar. I got a lot out of both of the panels, and particularly the discussions this morning with Dr. Sewell about complexity and how to get at that complexity, and your work on the complexity. As a community health ethnographer working with public health people over the last 45 years, that was always a problem for me, because it was like we have 10 variables and we're looking at the relationships. And early on, I remember in the 80s or 90s, you try to talk to black people, you have them in your study, and they talk about God a lot. But we couldn't control for God. We didn't have measures for that type of thing. So I enjoyed this, and I wanted to say also, I was happy to hear Joe speak, because I've known him since he first came. And when he talked about what he discussed with that passion, it's part of the spirituality of black people. I don't know whether any of you have read the book Race into Justice by John Powell. The last 3 chapters really lays out well about spirituality, and what spirituality is all about is loving others and reaching out to others. So when people want to come back to these communities, it's about that connectedness. There's a lot about academics that puts you into this solitary type of thing, and that's why I always say to people that that connectedness helps me to deal with the bullshit I had to deal with in the academy. You know what I mean, really? So the thing is, when I heard the thing about males, that's a particular issue. A lot of these issues are with regards to complexity. For example, the whole issue that you referred to in terms of social fathers. There is a whole tradition going back to Africa that continued here with informal adoptions, affective kinship, and all of that sort of stuff. Where I grew up as a tenant farmer in rural Virginia, 30 years ago, I was talking to people in my generation in North Carolina, and they started talking about how segregation had some very positive points for black people. And what those positive points were was the connectedness, the community fabric, that they were concerned about their kids, particularly black boys, because when I was coming up through those schools, high schools, et cetera, my historical black college, everything supported my ego. I mean, I was in everything. And what they talked about, if a boy isn't playing sports, and we have no ownership over the schools and all of that. So that breakdown of fabric, relationship between family, church, the school system, and all of that, you had some sense of ownership over those particular things. So they can explain those types of things. And black males are no different than any other males. Poor whites, as well as other whites, have always blamed things on black males. That's what Trump, that's what, and black people, or, you know, non-whites, that's what Trump is tapping into. You know, that particular thing of I'm not responsible for myself because those black folk and those brown people are taking these things away. And then there's the thing about violence, and this is the last part, I'm gonna give it back to you because there's a whole lot related to this, but the violence thing is related to hustling. And hustling is American. I had crack dealers that tell me that in the early 90s, that we are no different than the CEOs. They just have the whole world and we have 2 blocks of DC with the people watching us. And a lot of people don't know that in the 80s, one of the fastest, if not the fastest growing sector of the international economy were drugs, and right behind it were munitions, guns, etc. So when Ice Cube said, we aren't bringing this stuff, we don't have planes and all of that to bring this stuff here. So some of that violence with guns, it has come from elsewhere, and it's some of the stuff that's destroying Africa right now because guns and all that stuff still being sold.
Okay.
Thank you, Godfather.
Okay, so I think it's perfect.
Put your hands together for the speakers. I'm done. I'm out.
Drop the mic. Drop the mic.
Drop the mic.
Okay. I think it's perfect that we ended with The Godfather, and I think it speaks back to what I was saying earlier about the hardest working man in show business was James Brown, known as The Godfather. The hardest working man in academia, I would by far say, is Rayshawn Ray. And I cannot let this symposium close without us hearing a little bit from Rayshawn. So I hope that Dr. Rayshawn Ray would come up, just give his final closing thank yous, and tell us what's brewing for 2017 as well as 2018. So here's my brother, my pal, my colleague, and my newly tenured colleague, Rayshawn Ray.
Thanks, Chris. I don't want to stand in between people and food. Our reception is right after this, right behind here. So please join us. Please continue the conversation. I just want to give another thank you to Chris for organizing this symposium this year. I definitely think we need to give her a round of applause. She did a wonderful job bringing together everyone. Definitely thanks to the panelists. I think you all gave us a lot of food for thought. Thank you for being here, giving us your time. Next year, the symposium is scheduled for April 26th, so Wednesday, April 26th, 2017. So we always do it right around Perrin Mitchell's birthday. So you can always think at the end of April, right around his birthday in the middle of the week, is going to be the Perrin Mitchell Symposium. Next year, Wendy Laybourne in particular was pushing for us to do something on media and culture. So I think in light of thinking about Beyonce's Formation and Lemonade, if you haven't seen that video, essentially documentary or album, I definitely encourage you to go check it out. So that will be next year. The following year in 2018 will be Race and Wealth. So we will have some of the foremost scholars coming to talk about race and wealth. So please join us for the reception. President Lowe is going to give opening remarks along with a short video on Parent Mitchell. So hopefully you all will join us for that. And thanks everyone for tuning in on the live stream. We saw a lot of tweets, a lot of Facebook posts, and we thank you once again for a great symposium.